Hello, welcome back from the break. I am really excited to be able to introduce a new part of our STEMI X symposium. It's the pitch competition, or Pitch EM, or Pitchem, if you like to be fancy with it. Uh, I, I think this is a great way to get more interest and excitement around our area locally, because after all, we are in Silicon Valley, and I feel like it's a place where a lot of innovation is always happening. There's a lot of great energy here. And we really felt like this was a great way to kind of showcase a unique way that Stanford is positioned within our local region. So, without further ado, I'm going to introduce your hosts, MCs for this portion of the conference. We have Ryan Rivera and John Dayton. They worked really hard to solicit some fantastic judges. Some of them will be familiar to you from our previous roundtables, and also vet and seek out some of the startups that'll be participating today in our little pitchem competition. So, Ryan, John, thanks for doing this. Have fun.
Yeah, thank you. I'm going to share my screen real quickly to introduce the judges, and then Ryan's going to introduce the teams that are pitching today. I hope I get this right here. All righty, so our judges today, we wanted to reach out to folks that had a background in venture capital, in medicine, and particularly emergency medicine. And so our judges represent a nexus of that expertise. We have Dr. Rossner, who's UCSF and also the head of validation for Node Health. We have Dr. Katie Richardson, who's a pediatrician and runs physician outreach for Angel MD. She runs the pitch events that are focused on different specialties every month. We have Unity Stokes, who's nice enough to do double duty today, coming from a roundtable and now pitching as well. He runs Startup Health. They invest in healthcare transformers. They work on moonshots like getting cost to zero and increasing access to health. And it's wonderful to have him with us. We also have Sherman Long, who is from AliCorp. This is a group of physician investors based in New York. And finally, we have Dr. James Eady, who is an emergency physician and also a venture capitalist with Sante, and they focus on healthcare investments. And I'm going to turn the time over to Ryan to introduce the different teams.
All right. Thanks, John. So in addition to an excellent panel of judges, we've got a great lineup of startups who are going to be presenting here today. I'm going to tell you a little bit about each of them in the order that they're going to be presenting. We've got first up, Well, going to be presented by Alex Prokhorov. It's a digital health company that's focused on remote patient monitoring and provides like white label devices, an electronic health record system, billing support for hospital at home. That's a topic we've heard a lot about today. So very excited to hear this one. The next one up is going to be EM Guide. That's Akshat Patel. They have built an ambulance and EMS-focused teletriage system that is really focused on addressing health equity and appropriate care utilization. So that's going to be a great one. We've got Manovo coming up after that. That's going to be Robert Johnston and Jonathan Munoz who are going to be presenting that one. They've built an ecosystem of care delivery tools for, again, remote patient monitoring. Then we've got CPR Therapeutics. This one's a little bit different. It's Dr. Norman Paradise. They've built a technology-enhanced CPR delivery device, and it provides CPR with this kind of innovative circumferential delivery system. Then we've got ClearStep by Dr. Matthew Sakamoto. They've built an artificial intelligence-based chatbot that uses natural language processing to facilitate emergency medicine triage and care coordination, something very close to my heart as an operations professional in emergency medicine. And then finally, last but not least, we will hear from Hero Medical Technologies. It'll be Debbie Cantor who will be presenting that one. They've built a data-driven triage and wound management system for head injuries. Now, just as a quick reminder to everybody of the rules of the game, each team's going to have 10 minutes to pitch their innovation. They are going to have a timer that will be visible during that time so they can stay on track. And then we're going to have about 8 minutes or so of Q&A from the judges. I think for our judges, we would ask that you hold most questions and get through their slides. And then after all presented and gone through their Q&A process, we will confer internally and we'll come back at that final event this afternoon. The winner is going to get $5,000 and also consulting services from the Stanford EM Partnership Program. So that is our faculty that consists of VCs, private equity professionals, digital health executives, successful startup founders, and more, all for them supporting them for the next year or so. Really interesting mix of companies that are here covering, everything from medical devices to hospital at home tools, informatics, AI, each with kind of their own twist on how we can use technology to improve our ability to deliver healthcare better. So very excited to hear from these companies. Without any further delay, let's see if we've got Well in the audience so we can bring them up for our first pitch.
It looks like they might be in the other room, so I'm going to have them come to this pitch room. Give me just a moment.
You guys are very efficient because we're actually not only right on time, we're 2 minutes early. So we got 2 minutes to get well on board here.
We have planned for 2 minutes of fiddling in between each of these presentations, including this. That is. You notice the 10 and the 8 only adds up to 18, right? Giving ourselves plenty of buffer.
All right. So hopefully we can have him join us here. If we don't, I see two of our other pitchers in the audience, and we may just call one of them up a little bit early. I'm going to sit over to the green room real quick because I think that's where he probably is. Give me just 1 second, okay, guys? Hey, Alex. Hey, exit this room and come to there's the pitch competition room, and then we'll call you up onto the stage.
So exit this one?
Yeah, exit this one. There's like two pitcher rooms, so it's a little confusing. You want to.
Yes, so for any of other pitchers who might be in the audience, we do have a green room that you can hop out of here, you can hop into there, and you can use that room to test out your slide shares and your audio and your video and things like that. And then just make sure you come back to this room at least, I'd say, 10 minutes before your presentation. That way we can pull you up. And no problem hanging out here if you want to as well. There's no rules against observing the other pitches. Just don't disrupt them. Don't heckle. Please don't heckle your fellow competitors in this. But yeah, happy to have you in either room as you're preparing to pitch. But it sounds like
Alex here, so I'm going to go ahead and give him the mic, and then we'll let him.
Just in time, with 0 minutes to spare, let's bring him up.
So there's a little bit of a lag time between the invite. There we go.
Hi, guys. Can you hear me?
We can. Are you able to share your presentation, Alex?
Absolutely. Let me just pull it up.
All righty, and then I'm going to go ahead and turn on the timer.
Okay.
Right.
Can you see my screen or not so much?
Sure. There we go.
Co-founder of a company called Well. We're a digital health. Always been looking to expand our horizon, and I think our eventual destination is hospital at home solutions. So let me a little bit walk you through what we do and how we do it. But I'll first start by quickly summarizing some of the typical challenges that hospital systems face. Obviously, reducing readmissions, improving post-discharge care, physician efficacy, ever-increasing rising costs. And then with COVID, we saw some additional challenges. All of a sudden, there was a ton more patients looking for the bed capacity. There's increased health risks by coming on site. And then there was a also dramatic decrease in medical staff. So all of these things, I think, put the conversation of hospital at home and digital health solutions front and center. We've been doing it for quite some time. And some of the ways that the industry have responded, the first thing, they sort of remembered what telehealth was and how we've been talking about it for 10 years. I mean, that's great. The CPT codes finally started working. The other thing where we spent increasingly amount of time, that telehealth over the past 15 years became increasingly a commodity service. The other thing that became interesting is remote patient monitoring, where we're really focused on right now. And I think the way of the future is the hospital at home, where you really, in addition to offering not just a digital communication tool, device integration, which is what RPM is, you also bring integrating all these other services that can provide a much broader scope of care at the patient home versus in the medical facility. So that's kind of, I think, the natural industry trend. Where we are today, we're a digital health platform. We have a web-based platform. We have both the iOS and Android app. We integrate with EHRs. We have 300 plus devices of all different types, both Bluetooth connectivity, API connectivity. Work with different brands. We even have we white label and manufacture and know the manufacturers in Asia directly, so we can source product at much lower cost than most others. And what we've, obviously there's a dashboard where a physician can do all kinds of charting, taking medical notes. There's a billing module. I think where this all sort of is transitioning to is a open architecture that allows integration of best-in-class services, variety of devices, and variety of solutions to provide a more broader care than a traditional sort of a telehealth offering might be. And so if you look at what that hospital at home platform is, it's much more than just, hey, I want to speak to my doctor on Zoom or Teledoc. It's ability to integrate variety of devices, its ability to integrate lab, its ability to coordinate, various care providers that are in the home, its ability to deliver and manage medications, paramedicine, and all these things. And so really, when you talk about this, telehealth platforms, what I'd say 3.0, 1.0 being just, hey, here's a video consult. 2.0, it's video consult plus device integration. 3.0, it's integrating all these different devices into a single platform. And that's kind of how we build it from day one. It's ability to use APIs. You don't have to recreate the wheel, find the best provider, and integrate them. And so I think in the past, the mentality was, look, I'm the hospital system. It's all under one roof. It's all managed by me as many providers, where I think the hospital tomorrow is ability to bring the best-in-class service providers. It's really what we've seen in other tech venues, and other industry has been disrupted by tech. It's ability to integrate different platforms and different solutions into a platform that offers a broad view and a broad solutions to a client. Just a little brief history about us. We've launched and started as a kind of a therapist management network, so ability to coordinate different providers that go in home, so speech, physical, occupational. We were then we added our digital health capability, work and currently have B2C and B2B clients. Launched RPM, last year, built our first patients, and then really expand and develop that platform today. And then starting to integrate different pieces where we sort of, digitize healthcare first, and then on the path to be a hospital at home solution. We are a team that's really kind of tech first, 4 platform engineers. We've got 2 clinician advisors, 2 other engineers. Some of our, raised, several $1 million of funding, and have some good advisors. And just quick highlights: we serve 5,000 users and patients, 5 years of history. We've been doing this. I think one of the widest library of integrated devices, and we serve a variety of use cases. So with that, I'll just pause here and let you guys ask any questions. Thank you so much.
Okay, thanks so much to our well presenters. We'll turn the time over now to our judges for Q&A.
Great, Alex. Just wanted to start by saying congrats on all the traction, and very big fan of the hospital at home movement. I guess I wanted to clarify, maybe for the judging panel, like, who are your target customers? You mentioned, corporate clients, employers. Are you helping health systems enable to be able to provide hospital at home services, or is it an employer-based go-to-market going through the employers?
Yeah, so we don't necessarily focus on employers and don't focus on hospital systems. We will work with corporate clients who are looking for some to power their engagement experience with their user base through our suite of devices and wellness tracking, digital wellness tracking ability. And the other one is just sort of a smaller clinicians, practices who want to use our RPM services. And this is an opportunity to kind of showcase our tech with, somebody like, emergency department in Stanford, and see how maybe we potentially can partner up and offer some of our services there. But the core customers are smaller clinician and some wellness B2B clients.
Can you also talk a little bit about your competition and what differentiates you from your competition?
Yeah, absolutely. Great question, especially come from Angela MD, who's seen a number of these pitch decks in this space. I think twofold. One is the device subsegment that we're really focused on. We're really focused on kind of diabetes management. We're one of the only ones to integrate with Freestyle Libre, which is a leading CGM solution out there. Two, it's the ability to sort of bring it's the ability and the vision to sort of say, we want not just be RPM and that's it, but really transition, integrate other providers there, and being ability and having that experience with managing over 10,000 therapists on our platform before, and coordinating other care providers that can go into the home and really make that least baby step on the way to being a hospital at home provider. So I think it's the other thing is our business model. So like our pricing, we try to be much more price competitive than some of our other vendors, just by being scrappy and utilizing some offshore developers in the way we kind of structure some of our personnel. So it's really, I would say, kind of go-to-market strategy and device strategy that differentiates from other RPM players. And then two, being able to really have that vision of saying, what else can we do?
And Alex, if there's time, I have a couple of quick follow-ups to Katie and Sherman's questions. I'm going to put it right out there. Like, there are some big players in RPM like Validic. I want to hear how you're going to beat them. They have traction in a lot of health systems already. Question 2 is, do you have or are you planning to have EHR integration? And question 3 is, please put this in the perspective of the emergency room provider.
Sure. Great question. So, we, like I said, going back to our target market, we don't want to be in hospital. I mean, hospice is not our core segment. We'd love to partner with them, but we're not going to, raise millions of dollars, hire expensive B2B sales force, and engage in a 20-month sales discussions. I mean, if there's a relationship, opportunistically, we'll pursue it, but that's not our focus. So path to profitability, much greater number of providers, much more diversified business. Coming back to what we would say, let me just jump back to the kind of emergency physicians. What we want to do is bring additional revenue. We'd like to sell revenue. We don't like to sell expense line item. We love to talk about value-based care, but really we love to sell additional revenue. And so what we say is, in the emergency visit, we'd love to say is, look, what are some of the cases where we can bring this RPM capability to your patients? We'll find whatever device is out there. In fact, if not, we'll build one a device for you over time, but we'll get you whatever you need and bring you additional revenue so you can start monitoring these patients and bring additional revenue after you discharge them. That's kind of how we view ourselves working with emergency rooms.
Is there more time for questions, or we done?
I think we got 4 more minutes, right?
Oh,
yep,
good.
4 more minutes.
So
given you're going after.
Sorry, and question 2 was EHR integration. Is that?
Oh yeah, EHR integration. Yeah, I'm sorry. Yeah, so Epic Athena is on the way. Again, coming back, nothing different about there. What's different about us? I believe there's about 500 EHRs in the country. I don't remember the exact number, but it's a long list. And one of the things, again, because we've integrated with so many different devices, we know how to build solution that can integrate with EHRs that don't have APIs. And so we're in discussions with several of them. So that's definitely a go-to-market strategy. If we have a provider that has a small EHR, we'll tackle that right on. We have in the roadmap, we have a solution that sort of, can populate that data into the EHR, whatever they need. So that's absolutely in the roadmap, and we'll get the big ones out of the way. It's not too difficult.
I have 2 quick questions. Could you talk a little bit more about how the pricing works? Is it like a subscription model or by patients? And then a separate question is, who owns the data that's flowing through this platform?
Great question. So we have 2. Yeah, it's a SaaS model. We charge a physician a fee. One, so that we have 2-tier pricing. First one is a kind of go-to-market pricing model. Is basically we do everything for you and just produce you a billing file or integrate with your EHR where you bill for it. That's a more more expensive. But for physicians who say, hey, we'll use our staff to monitor and keep track of this data, we have kind of a basic, a more basic tier pricing. As far as the data, all data belongs to the provider and the patient. It's all governed by HIPAA. We can't resell the data. We can't touch the data. We just have to make sure it's secure. But obviously, the more data we see, we will partner and invest in data analytics and bring some additional insights to the providers. And already our B2B client is some of the leading kind of diabetes management clinics in the country. And so at least in our core focus is, I think we'll build some expertise and some additional insights in data.
All right, we've got 1 minute. I suppose any really quick questions from our judges?
Great questions.
Yeah,
Thank you very much.
definitely excellent questions, excellent discussion. Thanks so much to our presenters and our judges. We will have the Well team drop off. We're going to pull up. Yeah, applause is appropriate here.
Thank you. Thank you so much.
Great work.
Now we will, while we are working to have the EM Guide team pulled up, judges, this is a good opportunity to record any impressions or thoughts that you have. I think given the tight time frame, probably a good idea to do that during the presentations as well. But you can use this to kind of put together some summative thoughts so that we can, when we reconvene at the end of this, we'll be able to go over those together. And John, if you want to pull up, I believe it is both Akshat Patel and David Mui from EM Guide who are going to be joining us.
Yeah, they just takes a bit to load, but they are both coming off the stage. Got David.
I have just been informed that only 8 people can be on screen at one time here for this. I'm gonna see if yep, there we go. I've turned off my video and you can look at my picture instead, and that allows us to proceed. Okay, now we are 2 minutes ahead of schedule. Why don't we let you work on pulling up your slides too while the judges are continuing to kind of record things. Okay, that looks good, nice and smooth. Let's give our judges 1 more minute maybe, and then we will get started.
Judges, if you guys want to let me know when you're ready, and as soon as you are, I'll just start the timer then. Looks like Katie's ready. Sherman's ready. Unity, James. Ben's good to go.
All right, we will start the timer, and then EM Guide team can go ahead and get started. There you go.
Great, thank you. Hi, everyone. My name is David Moy. I'm currently an MD MBA candidate at Penn Med at Wharton, and I'm interested in both emergency medicine and digital health.
Hey, good afternoon, everyone. My name is Akshat Patel, and I'm a first-year MBA student at Wharton.
So we're both here to introduce you to MGuide, where we are empowering first responders to redefine the patient journey. Next slide. So I want to start out by talking about John. So John is a 55-year-old man living in West Philadelphia. I had the pleasure of meeting John about a year ago in the emergency department at Penn. John was the first patient that I saw that day. He told me that he was brought into the ED by ambulance and that he's been waiting to see me for over 5 hours. He was clearly upset by the wait and told me that he wants to be seen for his toothache that's been bothering him for a couple days now. He knew that it wasn't a medical emergency, but he came to the ED because he didn't really know where else to turn for his care. That day, I gave John the treatment that he needed and sent him home. But in the back of my mind, I wondered how I can ultimately change John's patient journey and get him the care that he needs at the right place at the right time. Because let's face it, nobody likes going to the ED, so how can we keep those who don't need to come to the ED out of the ED? Next slide.
We're on the next slide. Is it visible?
Oh. The slide hasn't moved for me. Has it moved for everyone else? Okay, got it. But this isn't just John's problem. Of the estimated 37 million 911 calls that EMS responds to every year, over 40% of them are for patients who have a low acuity, non-emergent illness. With low acuity patients overutilizing emergency medical services, this leads to increased healthcare expenditure, more emergency room crowding and wait times, and just overall decreased patient satisfaction for everyone involved in the patient journey. But at the core of this problem is health equity. So from national data, we found that Black and Hispanic Americans are disproportionately utilizing EDs for low acuity care and have lower access to both primary care and preventative care services. If we look at emergency department usage by payer types, we also see similar disparities in the Medicaid population, which represents 18% of the U.S. insured population, but almost 40% of ED visits and of EMS visits to the ED. So this represents our initial patient population that we'd like to target, the Medicaid population and people of color, before we expand into all payer types. So what drives the problem? We really identified 3 key drivers here. So the first is operational inefficiency. So patient triage currently occurs too late in the process. Patients are brought to the ED by EMS and just wait in the ED to see a physician, and this creates a bottleneck of patients waiting to see a healthcare provider. What if we can bring the physician earlier in the process before a patient even gets to the emergency department? The second is underutilized EMS. So EMS currently only stabilizes and transports all patients to the ED, regardless of their acuity level, and even for those who don't need to go. But EMS staff who are well-trained in triage and medical services are underutilized. So what if we can actually now assist with on-scene treatment of patients under the guidance of an emergency medicine physician instead of just transport? And the last is misaligned reimbursement policies. So currently, EMS are only reimbursed by insurance if and only if they transport a patient to the ED. And this creates a perverse incentive to bring low acuity patients to the ED, even if they don't need to be there, because this is how ultimately they're being paid now. So what if EMS can actually be paid for getting patients the right level of care that they need instead?
All right, hopefully the fire alarm doesn't go off. So the way we want to solve this problem is by empowering first responders to redefine the patient journey. At our core, we are an EMS technology company that allows triage to happen earlier in the process. First, we'll develop an EMS-centered platform that allows first responders to virtually deploy an emergency medicine physician to the scene. We want to pioneer the use of teletriage to allow the physician to evaluate the patient earlier rather than later, and allay patients of their anxieties and concerns while we're at it. On-scene EMS will be vital in providing medical information and treatment in tandem with the virtual physician, as they will also feel empowered to get the patient the right level of care. Furthermore, we will have a care coordination team in place to help reintegrate the patient back into the primary care services and connect them with patient-centered follow-up care that they need. So let me walk you through the current and the new patient journey. The current journey is in gray here, and MGuide's model is in blue. Currently, what happens is EMS arrives on scene, stabilizes, transports, and then the triage occurs. Under our model, EMS's role is expanded and more dynamic. They will be able to provide treatment in place, which we believe will be the majority of patients, or transport patients to an alternative care facility like an acute primary care center. Our care coordination team will make sure to follow up with patients, getting them coordinated with a primary care appointment as early as the next day. Patients will have greater access and convenience to primary care, but also get the reassurance that they've been seen by emergency medical services. Something that I want to highlight here is that under no circumstances will a patient be coerced into going to an alternative care facility against their will. They will take control of their own health by signing a legal form and voluntarily choosing not to go to the ED. To further align the incentives and leverage behavioral economics, we will offer instant payment for every diversion achieved by the EMS agency. The payment would be sent through our API platform and would provide an instant financial incentive to provide patients with the right level of care. Other innovative companies like Embedded Healthcare and Stellar Health have shown that this behavioral nudge is an effective way to incentivize healthcare personnel behavior. Not only do multiple stakeholders, that is, patient, payers, and hospitals, stand to benefit from our venture, but this is also the right time to seize the opportunity to solve this problem. There are several healthcare trends that enhance the utility of our product. We are riding the coattails of a new CMS regulation, as mentioned previously, and we will also be taking advantage of this regulation to ensure that EMS agencies are reimbursed even if they transport somebody to an alternative care facility. Furthermore, the increasing number of hospital closures, along with the recent rise in value-based care, makes our product that much more appealing. To determine TAM, we took the 37 million EMS calls that we mentioned earlier, and we took research data that indicates 40% of these calls are low acuity. Next, we assume to only be reimbursed by patients who have health insurance. And then we set a modest goal of only diverting 50% of those patients. And if we assume that each one of these diverted visits results in a savings of $400, then we have a TAM of roughly $2.5 billion. Now, something else that I want to highlight here is that our platform is going to be free to use for EMS personnel. Initially, our revenue will be generated by a fee-for-service model where we charge payers per patient diverted. Eventually, our revenue will be generated by a 50-50 shared savings model. In this case, we will enter into a partnership agreement with health insurance companies and agreement to drive healthcare costs lower. On the right, we have the per diversion unit economics layout based on a fee-for-service model. The EMS reimbursement will stay the same, but the majority of the savings is being driven by the fact that an ED reimbursement will be substituted by a primary care visit. On average, we assume or we expect a savings of $258 per patient diverted. This doesn't take into account the number of savings that will be incurred by downstream costs saved. Also, something to keep in mind is that savings will be higher for private health insurance companies. This is the team that we have put in place that is advising us besides myself and David.
All right, great work, guys. We'll turn the time over to the judges, and I'm going to go ahead and set a timer for the Q&A section as well.
Well, that's being said, great presentation. Could you share a little insight to where the service and solution is today in development or in market? Anything you can share in terms of traction to date?
Yeah, I'd be happy to take that question. So we actually, like I said, we're targeting the Medicaid population initially, just because of the high need there. And we've spoken to Pennsylvania's Medicaid director, who's very interested in piloting our program. And we had an initial meeting last week with 3 of the big payers within Medicaid managed care within Pennsylvania, so United Health, Keystone. And they were also interested in potentially bringing this into their program in order to trial it out. So from that standpoint, I think we have a lot of players who are interested in trying out our platform. And I think for our next step, what we want to do is really build out that technology API platform and start to deploy this on the scene. And Akshat and I are also visiting a couple of the innovative EMS companies in both St. Louis and Florida that have done kind of a similar sort of program within their own companies that they're trying to divert low acuity patients. So that'll also help inform us on how, as we start to develop our API platform.
Really great stuff, guys. And I love that you also have like a fee-for-service bridge in the business model, because as you guys know, it's really tough to land so many shared saving contracts. My question for you guys is, as I've been looking at other companies in the space, it's not like trivial to integrate with EMS agencies. As you know, some are private, some are public, some are run by the state, some are run by at the city level. So my question to you guys is, what's the go-to-market to integrate your software upstream where the 911 operators are kind of deliberating these calls?
So I think for our business model, we're not actually targeting the 911 dispatch center. We're going to intercept the call at the EMS ambulance at that specific portion of the patient journey. So there, you know, in terms of integrating with the software that they currently have, when we've visited EMS agencies, we've seen predominantly that they use a software called ESO. And so as we're starting to develop our API platform, we're going to be able to integrate with that existing software so that they can get patient information to them and to our virtual emergency medicine physician that allows kind of the seamless transition of care. In relation to kind of just more the fractionized EMS agencies and so many out there, I think we're going to initially target ones that have large presences within the area. So in terms of private EMS agencies, that would be something like an AMR, which has a large majority of the private EMS agencies. And for the public institutions, we would be targeting the fire department of the respective institutions that we're at, because they're taking most of the volume on the public side as well. So I think starting from there, in terms of our go-to-market strategy, we'll have a substantial number of patients that we can initially divert.
And as a follow-up question to what Sherman just asked, I'm going to sound a little bit like a broken record, but tell me what your advantages are over the competition, because I know there are several other startups out there that are trying to do exactly what you're doing.
So the major differentiating factor for us is like something that David already mentioned when answering Sherman's question. A lot of the competition we've seen are really 911 technology companies. We are more an EMS technology company. We're a little bit more downstream. And the sort of big advantage this buys us is that now you have medical personnel who are on site to help with this process, as opposed to some predefined protocol that a 911 operator walks through. So I think that is a big differentiator for what we're trying to do here.
Guys, very interesting, thinking about it from the clinical standpoint and trying to judge the patients that you're seeing out there. Do you anticipate having a physician, you got your medical directors, but are you thinking that you're going to have now sort of nurse practitioners or other advanced practitioners that are sort of on a FaceTime, better for worse, to use that analogy, or telehealth with the paramedic that's out there to try to help figure this out?
Yeah, so I think what really makes us stand out, and I think this adds on to how we're different from the competition, is that we're not just a solely virtual platform, right? We're not just having an advanced practice practitioner, APP, or an EM physician that's virtually evaluating the patient. We'll also have the EMS personnel that's currently on scene, and they'll be able to do it in tandem. And we think that in tandem works really well, because this both empowers the first responders like these EMS agencies, which from a lot of our surveys, we found that they're actually interested in taking a greater role in actually caring for the patient rather than just transporting them to the ED. So this allows them to do that within our process. And like you said, with the APPs and EM physicians guiding them, we think that that's kind of the right level of care that will be able to provide the patient both treatment in place or transporting them to an alternative, more acute primary care center where they can get care as well.
One thing you're going to want to really think about, having trained in the Northeast, practiced in the military, and I live in Texas now, and it was mentioned before. I mean, these EMS systems are a huge number of private equity owned now, or even if you get an EMS here in the city of Austin, it's a $900 charge. It's not $400, it's $900, and it's mandated. It can't be negotiated down. There are a lot of perverse incentives right now in EMS. Additionally, having experience of running pilot programs to try to reduce ER visits when the hospital is still based on a fee-for-service basis. While on one hand, somebody may say that's a great idea to reduce volume, what that also means is you're reducing revenue. And so getting the input from a CFO or finding the right system, whether maybe perhaps you check in the Geisinger system there, that it's not too far from you, or other systems, you may want to be finding one or a system where it's just got a payer that's attached to the hospital, right? Because I'm not sure that this is, when you think about how you roll this out and you're starting with Medicaid, the devil's going to be in the detail, and our system is broken for a lot of really good reasons. It's broken. And so as you come in with a digital solution, you're going to be running into some very historical things. And so finding that right test bed to go after and trying to figure out what all the pieces that have to be aligned to align incentives. Otherwise, you're going to find there's a lot of misalignment in your incentives out there. So,
yeah, I think that's a great point. And just to very quickly say, I think targeting these payvider systems like Geisinger, like UPMC that are within Pennsylvania are definitely going to be the first ones that we target, because that there you have kind of a better alignment in incentives rather than just a hospital system that might not necessarily be.
I know we're almost out of time. Can you pull up the slide with your team on it again? It went by so quick I couldn't see it. And I actually want to make sure I understand also a little bit of the business model in the sense that if EMS providers are incentivized for actually transporting a patient to the ED, is their reimbursement going to exceed what they would otherwise earn for transporting? And how are you going to combat that?
So in terms of the financial incentives now, actually in the state of Pennsylvania, even if EMS doesn't transport a patient to the ED and they provide treatment in place, they're still going to get that. They're still going to get paid that mileage rate for which they would have gotten had they sent a patient to the ED. So I think that part of the incentives is already aligned correctly for our pilot. I think the second part that Akshat mentioned is, changing behavior, we think, is one of the most difficult things to do. And in order for us to do that, we've kind of stolen an idea from Stellar Health that we know has done a great job changing primary care physician behavior by providing an upfront financial incentive on the spot to allow them to kind of change what they're doing and prescribing behavior. So we're similar to that. We're providing an upfront incentive for EMS to say that, hey, you've done the right thing of bringing the patient to the right place. You get this financial incentive. This helps your bottom line, but it also helps healthcare expenditure within the system in general.
I hate to cut you off, but we need to switch over to the next one. Presentation. Great answers for the Q&A. Go ahead and send everyone some claps your way, and I'll bring the next team to the stage.
I think it was only we gave you an extra minute, given you lost at least a minute of endurance there partway through, right? I think.
Sure.
All right, so judges can consolidate their thoughts while we bring up the Menovo team.
Well, that lighting is bad. Sorry about that. Just gonna pull up.
That's kind of a dramatic entrance, though, to start with the silhouette, and then
we wanted the mountains. That's what we're going for. Give you the mountains. I'm just about to share our deck. Can everybody see that okay?
Yeah, looks great. I'm going to put the timer on right now.
Great. So I'm Rob Johnson. I'm a nurse practitioner and CEO and founder and co-founder of Menovo. Menovo is a telehealth ecosystem that comprises innovative technology with the digitization of specialty and subspecialty cares. Some of our secret sauce, we can say, as we started out back in 2015, is we sought out a lot of basically ideas and advisors from the major industry experts, consisting of the likes of IBM, but also health systems like HCA and United Healthcare Group as a payer. And one of the things that we really try to deliver that differentiates us from the rest of the systems and solutions out there, as we discussed with these advisors, was there's a lot of opportunities for single point solutions, and there's a lot of cool technology, but technology itself does not deliver outcomes. It's clinicians like ourselves that actually deliver those outcomes in the ability to leverage technology effectively. One of the concepts that we discussed and in many pain points was the compliance rate. How do we make sure that we are innovative enough and smart enough in our predictive analytics and our ecosystem to actually replicate physicians and replicate providers, so that the patients have more access to some of those benefits. And one of the main targets that we found quickly, obviously, to reduce readmissions and to improve healthcare costs, was to target people in the emergency department. A lot of times we have an underprivileged population or an underserved group that comes in and has that interaction with a healthcare provider, and very frequently, as we know them as frequent flyers, they return for either a primary care issue or medication management or even just management of chronic illness, but due to access, they were unable to get the benefits they need. So Manovo really takes that innovative hardware, finds out the problem and solution through symptom surveys as well, and then provides a solution of onboarding, implementation, and education for that patient by replicating those providers. When the patient leaves the ED, they're given a QR code basically to schedule an appointment with one of our RNs or nursing leads or nurse practitioners or cardiologists, et cetera, and we provide that important education of what needs to happen going forward to reduce the risk of a return visit. Some of the discussions that we've had with some of the traction we've got in the market is definitely to have that robust virtual care platform. There's not an access to the specialty cares for extended periods of time. So once a patient leaves the ER, sometimes they can't get in to see that specialty provider for 4 months because of the backlog and because of patient overload. And so Manovo digitizes that specialty care and gets treatment options to the patient in a quick manner, and gives recommendations going forward to really prevent and to optimize their quality of life and prevent that readmission. That includes primary care and specialty cares.
In a conversation with the former CEO of United Health Group, we sat down and understanding that we're tackling, all of us are tackling this crazy Everest or this crazy monster. Steve Nelson made a comment to us, and he said, "You guys can't deliver another single point solution. You guys can't think too narrow." He's like, "That doesn't mean that you're going to be distracted or that you're going to spread yourselves too thin." He said, "But time and time again, we are feeling the effects of fragmented technology hit the market, and we're feeling the effects of hard implementation at the clinician and patient levels." And so he said to us, if you guys focus on those clinician and patient experiences, and you guys will develop a secret sauce that's going to set it's going to set Manovo apart, and it's going to set this whole thing into motion. That's been our focus is integration. It's knowing those fumbles because of our team being on the front lines, knowing where these technology implementations fall apart, knowing where the burdens on time usually hit first, knowing where the breakdowns happen, and being able to then focus in on those and not just, deliver tech into the hands of a health system or of a doctor or anything like that. And so for us, it really is, just to reemphasize what Rob said, replicating those providers in that digital way so that different specialties can implement digital pathways when it comes to delivering care, but then also that implementation and in-servicing. If we don't partner with them, if we just give, technology, it's going to fall apart. And we've heard at this point now, the likes of Steve Nelson and, Mark Briggs and others at some of these, at United Health Group and at some of the health systems as well, the strategy officers that we work with, where they show us the breakdowns. And so for us, I think what we hope is the biggest thing that, one of the big takeaways from this conversation with you guys is that this is designed by clinicians, by administrators, by even the mid-level staffs to prevent those breakdowns in implementation and to be able to actually deliver, on the promises that we're making to the patients.
So Manovo has a series of pillars that we focus on. Obviously, we have an integrated hardware. We have the patient providers, and we identify, the hospital at home, partnering with home health companies, post-surgical kinetics, cardiology groups, et cetera. And then we automate those services essentially with peer-reviewed based standards of care and put it into a web platform that then aggregate. Then we use our data gathering tool to refine those algorithms to give proper recommendations to the appropriate personnel, whether that's the health system providers or otherwise. Some of the things we also really pride ourselves on is the mobile application. We are a healthcare, obviously, and clinician-centered first and patient first. and then we add the tech on top. And we've designed our technology with our mobile application, our web application, for the geriatric population, or those that are in underserved areas, so that it's simplistic and easy to use.
How much time do we have left? Sorry, we're watching the slide, but we can't see the clock.
You had 2 minutes and 33 seconds.
Awesome.
Okay, so just with that, I think we'll paint a couple of use cases just so you guys have an idea. With United Health Group right now, we are in planning of a pilot with them for increasing the discharge speed, or reducing the time in a hospitalization when not necessary, and as well as a hypertension management program. With the Hospital Corporation of America, we are talking about virtual cardiac rehab, overnight oximetries, chronic care management, and I think when we discuss this whole concept of the emergency room and kind of a start point of rewiring the patient experience and the patient brain as to how they seek care, we see clear opportunities there to use the platform when it comes to some of its behavioral health capabilities and just some of the education capabilities to start to shift where patients go, how the patients take their health journey, right? So that they're not just doing what we have traditionally done, but do it in that new way based off of good sound data. With that, I think we'll pause there and we'll stop for questions.
Great job, guys.
Could you share? I'm sorry.
No,
could you share who you're selling or envision selling this into, and then who you envision paying, and a little bit more on how that business model works?
So we have targeted health systems and payers primarily. Obviously, there's chronic care management codes. There's virtual care for cardiac rehab reimbursement codes. There's pulmonary rehab, and remote patient monitoring as an ultimate resource. But that's where our target is, and that's where we've had a lot of success.
God, I was going to ask the same question, but I guess in order to bill for those codes, you guys would have to have your own PC stood up. And is that the intention, that you guys would have your own physicians and be billing those codes, or helping health systems build those codes and taking a slice of that?
Yeah, so we have it stood up right now, where the eventual endpoint for hospital at home, as we're going down the road, is that we would have an integration of multiple provider health system groups that enable them to bill appropriately in the subscription model here.
Sorry, subscription model for whom? Is it the patients, the health systems?
No, subscription from the health systems to us, to Manovo. Okay. So that's the B2B connection.
Yeah, for the virtual care platform.
Yeah.
And then the system bills the RCM codes, you're saying?
So we structure it so it's really simplistic. They help them build their notes, their synopsis of monitoring, whatever service that they've implemented, whether cardiac rehab or RPM or chronic care management.
So I love the comprehensiveness of your platform. I can tell that you guys did do your due diligence as far as talking to people around, how do we coalesce many of these services. It seems to me that this is going to be most useful for hospital discharges to prevent readmissions, hospital readmissions, et cetera, as opposed to necessarily in the emergency department. But can you speak to that a little bit?
Yeah, so one thing that as we go, I was actually the physician liaison in the ER, and my clinical experience when I'd float down to the ER, it was always, I have a patient that's here for a primary care illness, or I have a patient with the sniffles and sneezes, and I'm worried about traumas and things like that. And so obviously the target focus was there is a lot of busy individuals in the ER as well, and the appropriate education from a nursing standpoint, from a provider standpoint, sometimes gets cut. And so it was taking that load off of, as we've met with directors in various ERs, it says, what we've done is we've given that QR code to say, schedule the appointment so we can educate the patient more fully on what their condition is and what this looks like going forward, then secondary reducing the amount of readmissions.
Thank you. Can you also, sorry, one other question. Can you also tell us a little bit more about your team?
Yeah, so we have a great group of advisors. Like we said, we have the health systems. We're really clinician based and founded, I should say, as we have the variety of advisors in multiple disciplines, and a lot of which are on the screen right now. We have a robust software team as well to help us build the solution with a data team, mobile team, and web team.
Our lead of sales is a former medical device industry sales lead, and our on the commercialization front, and next to them, but also strategically, is a former hospital CEO, Cliff Park. The other guy's name is Don Dunn. And then, yeah, on the technology front, we have, anyway, yeah, it's we do everything internally. When it comes to the tech build, we haven't outsourced anything, but we definitely have gone healthcare industry heavy when it comes to sales, strategy, business development, and leadership, to make sure that we are infusing at every turn the technology with that, healthcare professional touch and expertise.
What are you noticing in the sales cycles, kind of in the post-COVID world, or whatever world we're now in terms of either whether it's a pilot or locking some of these down? What's the timeline look like? How's that process, and what have the challenges been?
Yeah, so we see small groups, small being in the 1 to 3 month range. The larger groups have been in the 6 to 12 month range so far. I think that the biggest thing that we have noticed is if they haven't yet jumped in, they have definitely learned a lot from their colleagues, and they're looking for comprehensiveness. They're looking for, maybe you don't do it all on day one, but you have to have that vision in place, or else we're not interested in another narrow solution. The ones that have already had that have already dipped their toe in, or even both feet have already jumped in, we're noticing, for example, the Chief Strategy Officer of Intermountain Healthcare, we have conversations going on right now, and he tells us that the group that's in there that just got kicked out basically crapped the bed. And he said to us, he's like, they made us lift too much of the load, and it was burdening the staffs. So it was, hey, they had a mobile app, and they had a web interface, and they had some devices, and they said that they could do all this other stuff, but they weren't doing those things. And so what we have noticed is, sorry, our light went off in its motions.
It's motion sensitive.
So anyway, that's been a little bit there, and then with the likes of United Health Group, it's and other groups like that, they're kind of pushing that next frontier, and it's what can be done from a behavioral health perspective. But definitely implementation and in-servicing, if that's not there, these systems are having a hard time dealing with new tech while handling everything else that happens on a day-to-day basis.
Thank you.
Where do you have any current deployments, and what does your pricing look like?
Yeah, so we have two subscription models, essentially based on the services and monitoring services of the acuity of the patient, I should say. It's $80 and $100 per patient per month, or per license per month. It's device agnostic. It's pretty simplistic. We've already started implementation in some post-surgical areas, and then also in some primary care models as well.
Have you had any pushback on an 80 PMPM? We understand that correctly? That seems unbelievably high.
No, so as long as we dedicate to say, hey, you don't have to hire out, you don't have to worry about the implementation, the education of this, and we're taking that load. The value prop has actually been pretty easy. We ensure that they're getting at least the RPMs of reimbursement, and then of course trying to help with more chronic care management and avoiding those readmissions. And so as long as we're selling that value prop, really accepted that pretty well.
Yeah, a quick insert, real quick, just from the other day. I know that we're out of time, but just to kind of paint that picture, because we were thinking the same thing, and we started with much lower end as far as cost packages, but they didn't have enough service. The other day, we were with one of the largest home health and hospice providers in the country, and we got to that point in the conversation, and they basically said to us, "We'll take that $100 package. We've already felt all of the pain when the technology provider doesn't lift the load alongside us, and we know that that's costly, so that's the package that we want." And we were kind of, taken aback a little bit because they were
so aggressive about it.
Yep.
All right. Thanks so much. That was a great question to end on. Thanks to the Manovo team.
Thanks,
and
guys.
applause here as well. Thanks to our judges for the excellent questions and discussion. I hope for those of us who are in the audience, it was a great opportunity, I think, to kind of see how experienced entrepreneurs and professionals in this space analyze these types of opportunities. So a lot of great questions. Let's bring up Norman Paradise from CPR Therapeutics onto the stage. And then judges, again, this is a good opportunity to kind of consolidate some of your thoughts on the last presentation while we have the next team pull up their slides.
Can you see that?
Yes, we can. We here in the control room are all smiling that we've had such a high success rate on screen sharing so far. It's excellent to see.
Well, the training was excellent yesterday.
Okay, good. Others in the room are just sighing in relief at hearing you say that. So, judges, are we ready to go? Thumbs up all around. You still need a little bit more time? Okay, sounds good. In that case, let's start the timer. And once you see the timer on the screen, go ahead and start the pitch.
Great, thanks a lot. We're honored to have been asked to present at this meeting. It seems like a pretty exciting opportunity. I'm Norm Paradise. I'm CEO and founder of CPR Therapeutics. Before I dive in, I actually wanted to mention that one of the first people we called when we put the company together was Paul Arbach, and he was tremendously helpful in terms of advice. And the other thing I think I'm going to mention is if my pitch doesn't seem very polished, I should mention that Dr. Richardson gave me a few hours of coaching last year. So I probably don't need to tell an audience like this that manual CPR and the automated devices don't work very well. They're really only minimally effective. You guys see this every day in your practice. But I thought I would put some numbers in front of you. This is the last big clinical trial, the paramedic trial, and the survival in the two groups were 6% and 7%. And this was world-class EMS providers who knew their performance was being matched. Being watched. In most communities, the outcomes are actually worse. And again, I probably don't need to tell this audience that sudden cardiac death is the largest killer in Western countries. Every startup likes to think that it's taken on a pretty big problem. We're pretty certain that we have taken on a pretty big problem. And I personally think that in all of biomedicine, this might be the most missing medical device. Human beings aren't going to be the answer. When paramedics know that you're watching and recording their performance, they don't do chest compressions 60% of the time. And during the time that they are doing it, they are too deep or too shallow 70% of the time. Lay investors are shocked when we put this in front of them. They can't believe that after 60 years, there's been a minimal progress. This is likely because they get most of their experience with resuscitation on television. Here's some data from a New England Journal paper I wish that I had authored myself, showing that the range of outcomes is at the low end, Chicago Hope at 60%, and Rescue 911 at 100% initial survival. This extraordinary situation of 300,000 deaths a year and essentially no progress was actually not a research failure. We developed a better type of CPR 30 years ago. Circumferential pneumatic compression can put in 3 times the motive force while avoiding the 70% rib fracture rate of the other techniques. The original vest is pictured here in blue. The green and red are additional pump mechanisms we subsequently developed. As an aside, this never got commercialized because the Bay Area VCs who licensed it decided they wanted to fail fast because the batteries of 1990 weren't adequate for a portable device. We continued to innovate despite the fact that it didn't get to the bedside, and developed almost a dozen additional enhancements that are listed here. Simply put, CPR Therapeutics is developing the first advanced technology automated CPR system that integrates multiple pump and electrophysiologic innovations in a single device that can be easily applied under emergency conditions. This multi-pump CPR cannot be done by humans. The existing alternatives, the Zoll device, the Stryker device, and manual are off to the right, and you can see there's little or no innovation with those. I don't have enough time to go through actual data with you, but here's a pig model of cardiac arrest. And if you look to the right, you can see the indicators of blood flow. We're randomly cycling the pig between CPRT multimodal, manual, and the other devices. And you can see the effect is not subtle. You don't need statistics. The period of CPRT, CPR, the perfusion pressures are nearly triple the alternatives. Again, I likely don't have to convince you that the addressable market for an effective CPR device is going to be quite large. If we have a positive clinical trial in the end, this would not be a discretionary purchase if it was priced reasonably. And we can make our monitor defibrillator a pop-out module, leveraging the CPRT system's market penetration to a full product line. I also don't have time to go through our intellectual property in detail, but I will share with you that we went dark initially and filed on every combination we could think of. So far, every application that has been examined has been allowed. So suffice to say, we feel that our IP moat is pretty deep. Our regulatory and product development plans are synergistic. Multimodal CPR, which is on the right here, will be developed through a series of staged 510Ks, each with a breakthrough designation. But importantly, step number 1, a cath lab version of the vest only, is itself an extraordinary minimal viable device we can commercialize in under 15 months. In whisper discussions with cardiologists, we've gotten significant pull for this device as a cath lab. They understand that pumping 3 times as much blood while having no rib fractures is a device that would be helpful in the cath lab. Also don't have time to go through the details of our team in general. I do think of us as the opposite of many startups. We're definitely not a bunch of 25-year-olds who went looking for a project in one of the current trendy technologies. All of us have worked on this problem for more than 30 years. NIH reviewers recently described us as essentially the dream team for this problem. Speaking of the NIH, we recently got some very good news. Our applications to develop multimodal CPR were enthusiastically reviewed by the NIH and the NSF. I initially thought our score was a practical joke because I had never heard of an NIH score that low. So fingers crossed, we're hoping we'll be getting a check for $2 million of non-dilutive funding to develop multimodal. We've already raised $450,000 from angels and hope that the remainder of our Series A can be directed at commercializing the cath lab device. Here is a prototype of the cath lab device, and I kind of lost track of where I was. Okay, a few additional details. The vest is like a large disposable blood pressure cuff that goes on in under 20 seconds. The CPR and defibrillation electrodes are on the inside, so things can be synchronized. Unlike sternal-based devices, it will be effective in the obese. And once there is return of spontaneous circulation, it can act as a non-invasive aortic balloon pump. The thing I want to leave you with is that we believe our company, compared to many others, is significantly de-risked. All system innovations are already done. We spent $16 million of the NIH money doing that back in the 90s. The engineering pathway is straightforward. We feel there's minimal to no technological risk. Our cath lab system is a good, minimal viable product. Our IP and regulatory strategies create significant barriers to entry. Solutions to the clinical trial are already known, and the technology creates a pipeline of products with digital data streams and disposables. We're currently in discussion for partnership with the large strategic companies. Thanks again. We're honored to have been asked, and I'd be happy to answer any questions.
I have one question to start with. Great to see you again.
Yes.
And so it seems like by looking at your timeline and some of your initial funding was a ways back. What is taking you so long to get to market?
Well, Katie, that is a difficult question. It turns out that when you approach investors and you're the only one working on something, that is concerning to them. They would really prefer that other people validate the problem by also working on it. We've had good success, as I mentioned, with angels, but the VCs have really moved away from pre-revenue companies. And basically, we're keeping our fingers crossed, as I said, for the NIH at this point.
Really great presentation. How expensive is this device, or how, what's that look like even over the next couple of years as prices come down? Love to know that. And is this, you mentioned the obese, but all ages, can this be used for all ages, all sizes of people?
Yes. Thanks a lot. Those are two good questions. I'll do the second one first. The vest is what changes. The pneumatic unit is built from the beginning to handle the morbidly obese, and it can easily handle norm-sized patients or pediatric patients, but you would have to swap vests. Remind me again, the first question was? Oh, price?
Pricing.
Yeah. I'll share one of my favorite anecdotes. We did a walking, talking tour with EMS directors a few years ago, and one of them said to us at the end of the talk, please don't tell me this is going to be $300,000. You'll bankrupt us. We're planning on a price for the cath lab device of $24,000. The two current devices, which are no better than manual, have average selling prices of $17,000. And for fully developed multimodal, we're thinking will be in the high 20s, low 30s. And there will be a disposable. The vest is disposable and will cost something around $100.
Okay. Maybe a follow-up question to that. So maybe Unity was getting at like the actual cost of the device, like COGS. Like how much does it cost to build the device?
We do have the cost. Sorry about that. We do have the COGS for the cath lab device. It's depending on volume between $9,000 and $11,000.
Okay, good. And then my full question would be, assuming your stakeholders like the director of patient safety quality at a hospital, like what is the equation in their head of like how much reduction in deaths that they would need to see? Like walk us through as if you were pitching that stakeholder, like what the sort of internal economics are going on in their head.
Yeah. So as I said, the current technologies that put about 80 newtons of force into the sternum fracture the sternum and ribs about 70% of the time. The number of fractures with this won't be zero, but it'll be very close to zero. So you're going to be dealing with significantly decreased morbidity. Now, we do hope the device is significantly more effective. And I guess you could make the argument if the DRG is in place already, the profit margin is better if you don't resuscitate the patient. But I would mention one last thing. We're the only people working on enhanced non-invasive CPR. There are more than 30 groups worldwide working on emergency ECMO. And the average cost for those cases runs more than $500,000. If people get delivered to your hospital, having had minimal blood flow en route by EMS, and you then do emergency ECMO on them, you may start their heart, but you could be dealing with a significant neurologic injury that our technology would have addressed pre-hospital.
Norman, congrats on your, I'm not sure if it was an SBIR score of 24. That's a pretty darn good score. So that's a positive indicator sort of in a, kind of an academic context. I want to ask a question about practical context in the ED or any other setting, which is in a real life setting, how easy is it to get the vest on a patient who's in cardiac arrest when there may already be a ventilator in the room, the patient's got an AED going there as well. So practically, how easy is it to get this thing on, to pull the compressor along and sort of squeeze this all into a room that's already pretty full?
Yeah, Ben, that's a great question. And it's actually one of the ones the NIH really drilled down on. The hose can be significantly long. So the power unit could be placed wherever it would fit. The NIH actually made us run a little simulation to prove we could get this on in under 20 seconds. Basically, you can't do it alone. It takes two people. Someone needs to put the patient on their side and then bunch the vest up against them. And then you let them lie down on the bunched up vest and pull it through. Our time to put on is pretty comparable to the AutoPulse and the Lucas devices.
One other thing, it's got the gears turning, which is, you could imagine in a future state, your AED built in, your therapeutic cooling devices built in for post-ROSC. I mean, there's a lot of sort of potential that could be added on. Have you guys thought about, that's probably distant future, but have you thought about those sorts of add-ons?
We have, and I will share with you that if you look at the human factor complexity of putting an AED on correctly, this is actually not that much harder. It's just, again, a big blood pressure cuff you have to get around the patient. The AED is built into it. So we have thought a little bit about a health club or airport application for this.
Is there a way, could this be used by everyday people, or does it have to be used by EMS, clinicians, etc. in the future? Like, is that a potential possibility? And then what would it take to get this from $9,000 to $11,000 down to $1,000 to cost, to build out?
Yeah, and again, some great questions, Unity. Yes, we really do feel like this could be simplified. Again, the NIH actually asked us to do an additional simulation where we literally grabbed people in the hallway at Johns Hopkins, gave them just about 30 seconds of instruction saying it's a big blood pressure cuff with Velcro. You need to get it around the chest and the abdomen. And they were able to do it. So you really could see a health club installation where you gave the staff a brief introduction. The cost of the unit flows from the high flow custom valves and manifolds for the pneumatics. And pneumatics is a mature enough technology that it simply defaults to volume. And so we were conservative in our projections in the first few years, so we were not ordering a heck of a lot of those valves. But if we succeeded, I don't know if we'd ever get it down to 1,000, but we could go lower than the current projection for COGS.
I was just imagining I could see it in every airport, every school, every, could see them all over. So thank you.
Yeah, from your lips to someone's ears.
All right. Sounds good. Well, thanks so much again for another great presentation and for great discussion and questions after the fact. Why don't we have the CPR Therapeutics team drop off? I believe we do have ClearSteps waiting in the wings. So we will pull them up. And again, our judges can take just a moment here to consolidate some of their thoughts. Yes. Yep. And I believe ClearSteps, correct us if we're wrong. It is not Matthew Sakamoto who's going to be presenting. It is Andrew. Okay, there we go.
Yeah, Dr. Andrew Johnston.
Andrew Johnston, excellent. And Andrew, if you can go ahead and pull your slides up while our judges are finishing up with the last presentation.
How does that look?
Okay, excellent. Yeah, now there's going to be so much pressure on our last presenter since we're 100% on slide sharing so far. Okay. Well, thanks. So this is our ClearStep team. Judges, do you need a few more moments, or are we ready to go? No? This is a fast crew. Okay, excellent. Well then, Andrew, once you see the timer pop up, then you can go ahead and start the pitch.
All right, sounds great. Thank you so much for having me. So my name is Andrew Johnston. I'm filling in for Matt Sakamoto today. Something about a beach in the Caribbean. He couldn't make it. So I'm an intern at a community hospital in Chicago and an incoming radiology resident at Stanford. I'm also a member of the clinical intelligence team at ClearStep. And today I'm here to tell you about ClearStep and one of our newest products in development, which is the Clinical Quick Start Summary. So do you ever have a full waiting room in the emergency department and wish you could know more about why a person is there than simply cough or my chest hurts? Do you have a farmer there telling staff that he feels fine, but his spouse made him get checked out? During a busy shift, it's important to triage and prioritize the sickest patients first. Effective triage requires someone with medical expertise, usually a nurse, to ask a series of questions about the patient's chief complaint and assign a triage level to the encounter. It also requires patients to understand the questions and answer them accurately, which may or may not happen. Now, wouldn't it be great to free up this triage role and give those medical professionals more time to spend evaluating patients without having to extract and then re-extract all of the same basic facts? And wouldn't it be great for patients to know that their entire care team was on the same page with regard to why they're there and what help they need? So during the pre-hospital course, a patient will often go through multiple rounds of evaluation by different healthcare providers. This can include questioning from EMTs, triage nurses, telehealth or urgent care clinicians, as well as primary care physicians. Each encounter involves a lot of information transfer between patients and healthcare workers. Many times the information gets lost in transmission during handoffs, details of the stories change, and patients get frustrated when having to retell their story over and over again to unknown faces in an unknown role. The loss of patient-reported information during handoffs and the frustration patients feel when asked, "What brings you in today?" multiple times by people they don't know, are problems that all of us have experienced in our work. So we asked ourselves at ClearStep, is there a role for technology to first help patients communicate their concerns more clearly in a standardized way, and secondly, to augment the human resource time required to gather basic information from patients? So we know that emergency room visits or volumes are on the rise, with an estimated 130 million visits each year. Additionally, many departments are experiencing staffing shortages, especially among nurses who perform those initial triage assessments. And with these strains on the systems, imagine if we could make pre-hospital symptom triage as simple as receiving a well-delivered one-liner. At ClearStep, we power a virtual triage engine that accurately and efficiently routes patients to the most clinically appropriate level of care. In a blinded concordance review we found that our chatbot triage recommendation matched an emergency medicine physician's recommendation 95% of the time. Our clinical algorithms are based on the gold standard nurse call center protocols and are continuously validated by a team of clinicians and user experience designers. Our product is currently deployed in multiple different contexts, including CVS Health, HCA Healthcare, and a newly announced partnership with MedDecision. Here's an example of a conversation with an 86-year-old gentleman whose chief complaint is fever. Our interaction starts with the patient entering his symptoms into a free text search bar. And then our natural language processing model matches his symptoms to an existing protocol. In this scenario, the patient searched for fever and was matched to the fever protocol. We begin the conversation by asking some basic demographic questions, followed by red flag symptoms that would warrant a 911 call or emergency care. We then ask about associated symptoms, such as vomiting or abdominal pain, that we can then characterize by duration and severity. And finally, we gather information on his medical history that would influence a triage result for that chief complaint. For example, we would want to know whether the individual has diabetes, recently had a surgery, or is undergoing chemotherapy. We then provide a triage result that tells patients when and where the patient should go to seek care. These endpoints range from you can probably take care of this at home to 911 in the emergency department, with in between such as you should call your doctor now, or you should go to an urgent care. We're generally able to complete each conversation in 2 to 5 minutes and ask less than 15 questions. But as you can see here, even a short conversation can generate a large amount of information. Our solution to deliver information efficiently to the emergency department is the clinical quick start summary. The goal here is to use our NLP expertise we've developed to synthesize all the patient entered information captured by our chatbot. We can then use the information to generate a triage level and a quick start summary in the form of a well-written one-liner. The summary can be transmitted easily to the receiving side of care and incorporated into the patient's medical record. We envision these quick start summaries as a starting point for a triage note, medical screening exam, or even the beginning of an emergency room history and physical. Think of it as a sophisticated dot phrase. So there are a lot of other symptom checker chatbots out there, and they tend to deliver an entire list of positive and negative symptoms. Our aim here is to streamline communication by delivering just the most pertinent positives and negatives for a given chief complaint. In order to test the feasibility of this approach of clinical summaries, we implemented a COVID-19 symptom screener for employees at a large multi-hospital health system. In the first 2 months after implementation, our triage logic automatically diverted what would have been over 1,000 triage nurse phone calls to self-service. And for employees that had symptoms requiring video triage, delivering pre-populated symptom summaries to the employee health staff saved an estimated 25 hours of triage time during that same period. This was a welcome relief to the 2 nurses who were inundated with phone calls during the Omicron surge last winter. So here's a little bit about our clinical team. It includes clinical intelligence from emergency medicine clinicians, physician informaticians, and engineers with a broad range of experience. We strive to be as accurate as possible and to create a user experience that is patient-centric yet clinically relevant. Our virtual triage product is already in production, as I mentioned earlier, providing triage recommendations for over 300 unique symptoms. We're excited to share that we are nearing our 1 millionth completed conversation coming up soon. This tells us that ClearStep is becoming a trusted source for people to turn to when they have symptoms and don't know where to go or what to do. With the addition of clinical quick start summaries, we believe that we can improve communication, efficiency, increase ED throughput, and reduce the burden on overworked staff. Our mission at ClearStep is to make it easy for people to access the most useful, clear next steps for health and care. And we believe that in collaboration with experts at the Stanford EM Partnership Program, we can develop and deploy tools towards creating a world where everyone gets the right care at the right time, at the right place. So thank you. And I can take any questions you have.
Great job. I love your product. And as you mentioned, there are a lot of chatbots out there, but I think you guys are doing something unique. So very cool. One of my questions is, can you talk a little bit about your business model? And as I was thinking about it too, kind of on the other side of that, so let's say CVS is paying one of your payers for this service. So then do they direct all patients at the, I'm going to say, urgent care level of triage to one of their clinics? Or how does that work as far as determination of where patients might be directed to go?
Sure. I'll start with the business model. So we offer a core triage deployment for kind of all our protocols. We also have some add-on products as well, one of those being a COVID symptom screener. That was initially our first product that we developed in 9 days at the beginning of the pandemic for Baycare and have kind of maintained since then. So that's a fixed fee per month, not per user per month, but per month. And then any additional services are added onto that. And then in terms of the second question, is we have APIs that plug into, or we're able to plug into all the site APIs for any given health system. So for CVS, they have their network of Minute Clinics, et cetera. And we're able to, the content comes from us and we white label it for them in their website. But suppose it comes out with an, urgent care endpoint, it would then direct them. They have the control to direct it to one of their sites of care.
Great. It's great to see all the traction and especially the use cases in that COVID case study. I guess my question is around just from the perspective of an emergency department, it's great to see you guys, at CVS and from a health system perspective, but when a patient has, what they think is a true emergency, how do you convince them that ClearStep maybe is the first step to start triaging their symptoms, or maybe that's not the primary use case for this particular solution?
So just to shed a little bit more light on that, as I mentioned earlier, we do white labels. So we are partnered with health systems. So as a patient myself, if I had symptoms, the first place I would go is my health system, right? One of the places I would go, Google. It would be Google. And then if I thought about it a little more, it might be the health system that I go to. And so because we go with those health systems, we use all their, we have our own website, but we don't expect people to come to the ClearStep website to search their symptoms initially.
How are you then measuring or pitching the ROI to your customers? That's question one. And question two, I'll have about it's accuracy related.
Sure. So the ROI, what we found from is mostly a cost savings ROI for the systems that we work with. We're able to measure that from previous deployments that we've had, and that's kind of the main pitch that we have to the health systems we work with.
But if CVS is a customer, how is there an ROI for them?
So in a couple, sure, they with CVS we can direct them to their different sites of care. So if and each visit earns them a certain fee for that visit. So we can drive CVS revenue for CVS in that way. We've also done the same thing for vaccines. So we have a vaccine eligibility checker that we use that has driven revenue for health systems who have used it for each vaccine that they've given.
Okay, and last question having to do really around accuracy and safety. There was a good paper in 2015 in British Medical Journal by Semigram that sort of compared a lot of symptom checkers that many of which also did triage. And you look at things like incorrect triage, which could be a patient safety issue. How are you assessing kind of the accuracy?
Sure. So I can first mention that the internal concordance study that we did, where we were 95% concordant with community emergency medicine doctors. The first 2.5% of that was due to us not asking individuals if they've already seen a provider. If they hadn't seen a provider, we would up triage individuals. And then the other 2.5% was just from us kind of playing it safe and us up triaging patients from their symptom result, from the characteristics they had chosen. We have a very robust system for reviewing past triage conversations, and we have yet to find an example of us under triaging a patient, just given our internal physician review. And we attribute that to probably our emergency medicine bias, as these algorithms were written by emergency medicine physicians.
Question as far as where this goes, if you think about it down the road, right? It starts with being able to take in this information and look at it. Do you see this sitting underneath some of the ER triaging systems? So it's not just a patient entering information, but if you think about all the information the nurses enter, there's so much data that's collected on triaging a patient, on early cases, and heck, you can run through the entire episode of care that's being collected. Do you see that as a space that you evolve, or do you think just sort of sitting down and coming up with, look, I can help you, that this is an ESI 3 is the end goal?
No, I think we have goals and ambitions to go a little bit further. Specifically, as I mentioned before, with this quick start summary, we hope to at least reduce the burden up front for triage, so that instead of information extraction, those individuals doing triage are doing more confirmatory questioning at least at the very beginning, before they do see either an emergency room PA or an MD. Something else we're also working on is being able to predict possible diagnostics that might be done for a patient when they do go to each side of care. And if appropriate, and if that's something the health system wants, we can also tee up order sets for these providers as patients come in.
It certainly feels it's nice to have a very focused application for it, and certainly the triaging, and it makes a lot of sense with the CVS and think about that primary care, low acuity. It's not really primary, it's acute care setting, but not an ER necessarily. Makes a lot of sense. So it's there. I think as you think about how do you extract value, how do you get that ROI back, what is that right customer for you, how do they fit it in? It's going to become, as you scale, can you get smarter? Those things like that, that'll really help your business grow, rather than it becomes another ER triaging thing. The ESI system was developed back in the 90s and was definitely a big advance in triaging. So if you can advance on that, those things to think about.
Okay. Well, thanks so much to our ClearStep presenters. Thanks so much to our judges for those excellent questions as well. Applause for the ClearStep team as they step down off the stage. We are coming on to our final presenter. It will be Debbie Cantor for the Hero Medical Technologies team. And we are a little bit ahead of schedule, right? I think it is 1:24, and we are scheduled to start at 1:30. So we have harvested 6 minutes over the course of this, which I think we will take and roll into our deliberations, because I think it's going to be tricky deliberations given the quality of the presentations we have. And happy to see that Debbie is carrying us home strong with a successful screen share here.
Yay!
Yes, excellent. So judges, are you ready to go? Thumbs up on this. Do you need a little bit more time to consolidate? No? Okay. Well then, Hero Medical Technologies team, when you see the timer pop up, go ahead and start the pitch.
Great. Okay. Hi, good afternoon. I'm Debbie Cantor. I am the CEO and founder of Hero Medical Technologies. We're based outside Jacksonville, Florida, near the Mayo Clinic, where we were the first company to graduate from their life sciences incubator here. Thank you for having me. I'm thrilled to be here to share with you what we believe will transform how we bandage, triage, and monitor head injuries and other traumatic injuries throughout the patient journey. To give you a bit of a background on myself, I am a geriatric nurse practitioner. I trained at the University of Pennsylvania, where I sat on the clinical faculty for 6 years before moving down to Florida. I maintain an affiliation still through the Center for Global Health. Our company was awarded a Johnson & Johnson Innovation Challenge, and to help validate what we believe is just, we know, and I don't need to preach to the choir here, you all have managed head injuries, I'm sure, many, many times. So we're tackling this very acute problem of head injuries in the pre-hospital, hospital, and post-acute phase, specifically during the first 72 hours of injury. These numbers, 3 million ER visits each year, don't really lay out the appropriate scenario of the severity of it. Around the world, it's estimated 69 million people across the globe suffer from head injuries. I believe that part of the issue is that it's such a nebulous diagnosis. I'm sure everybody's tackled, do we keep and observe the patient here? Do we send them home? And there's so many factors that go into it. Unfortunately, they're just, despite all the clinical skills, 50% of patients with severely head injuries die before ever reaching the hospital. So when minutes count, we need that efficient care. And it's sad that in 2022, we are still wrapping head wounds the way we have during ancient Egyptian times. This photo in the middle was an actual patient in Jacksonville, Florida. He was in the newspaper. It took 4 hands, 2 paramedics, and they still couldn't stop the bleeding. And that just delays time to get to the hospital, to get you all as ER physicians, nurses, and clinicians. So our goal was not only to create a faster method to stop the bleeding, but then to improve the entire process throughout the patient journey, whether it's in the field or once at the hospital. The photo on the right is actually my aunt, who sat in the hospital in Florida for 5 hours, still bleeding, waiting for a CAT scan. Fortunately, it was fine, but during that whole time, she only had one set of vital signs. So you end up with a chicken or egg. Did she fall because of a cardiac condition and hit her head? We don't really know. So by not having that early data, we're missing a big part of the picture. Also, as a mother of a child who did require, neurosurgery for a shunt, multiple trips to the ER, I know that every minute counts, especially in view of, a recent mass casualty at the school the other day. I just want to mention part of why I developed this solution is specifically because at the time that I had to take my daughter back to the hospital when she was 8, there happened to be a mass shooting in Amish rural Pennsylvania. And so thinking back to that time, I realized, had there been a better solution to pop a cap with sensors on the head of each and every child, perhaps some of the children would have fared better. My daughter did okay after a week in the neuro ICU, but some of the other children did not. So I thought, have a solution from the field to ambulance and triage and send the information throughout the process. So we developed a fast, smart, data-driven solution. Our bandage was tested preclinically at the Mayo Clinic in a simulation study where we put just one single sensor, a force sensor, under the bandage. And we had neurosurgical nurses and neurosurgeons on a walk-in basis test out our bandage versus standard of care. Ours was 3 times faster, though they had never seen it before. And 100% of them were able to do it by themselves, whereas otherwise 30% required help. To triage, our goal, we're in development now to add all the vital signs, including heart rate variability, to monitor. We want to have a default setting where each of these 3 stages can be are compatible, but can be used in isolation as well. Not every head injury is a bleeding head wound, and not everybody needs vital signs monitored throughout. We're using back-end algorithms from NEMSIS data currently for research purposes. We've applied to the NIH with the Mayo Clinic to study massive data sets of 23 million ambulance patients, looking at all the head injury diagnoses and developing formulas by synthesizing the vital signs to look at what are the most important features. Notoriously, we've been using Glasgow Coma Scale, but looking at the data, that's not really the best element to be focused on to classify whether or not somebody needs a CT scan. So the way it works, we analyze the data, we saw gaps in the system. Unfortunately, according to head injury studies, monitoring vital signs every 3 minutes can improve survivability 3-fold, but in reality, that's just not done. On average, they're checked every 6 minutes, and the longer the transport, the less often they are checked. So we're coming up with early algorithms. I've published at 3, we have 3 abstracts with the DoD. We've published with the military and with Mayo Clinic as well. And our goal is really to look at the most meaningful outputs. So this has been validated and continues to be validated as an unmet need. I just flew back from DC this morning after having a tour of Shock Trauma Hospital in Maryland yesterday, speaking with Department of Defense stakeholders. We just won a small DoD award as well to assist with our breakthrough device designation, for which we have a consulting firm filing that with us. It's in draft form now. And we know the market opportunity is tremendous. Now, we're not tackling necessarily concussions, the 95%, but the problem is that many of these numbers are because of under triage, specifically older adults, where 24% of older adults are sent home from the ER without having the care they need necessarily because their Glasgow Coma Scale might be 15. They take a turn for the worse and get sent back. Our goal is per unit sales of the bandage first, and then also per unit sales of the sensor technology, which will be just wearable, adhered to either the forehead, wrist, chest. But we just received another patent for alert lights so that, you can see from a distance. In the ER, it would be useful. If you see red, green, green, let's go check on the person with the red light flashing first. Market is just tremendous with all the ambulance rigs, hospitals, as you know, military, and home. Our extensive portfolio is growing. Again, we've been bootstrapping. Other than $50,000 from Johnson & Johnson, we're under a small FDA grant now for pediatric devices through Southwest Pediatric Device Consortium. We've really self-funded most of this with full freedom to operate. We do have interest in our sensors by 3M, and we're talking to Philips as well, potentially for Series A funding. We have an expert team, Tom Dugan. The MSN is not his, it's mine. He is a former president of Smith & Nephew. He's now with the president of Integrum. He was CEO of Sonosite Ultrasound. He also worked with one of your colleagues, Mike Blivis, an ER physician with expertise in ultrasonography. Some of you may know Amit Vora. He just brought to market his mobile MRI machine for prostate, and they have one as well for head injury. We have sales. That is my son on the right. He's been helpful with our strategic partner, NLP Logics, that's run a lot of our data science. Sharon Whiteman is my wife. She's former Navy lieutenant. She worked with a startup that sold to GE. We have neuroscientists and abundant strategic partners. We're working with Foley Lardner for corporate strategy in Boston. Again, Alira Health, we've partnered with MoodMe. MTech is the military consortium I just came back from, and we have received funding from IO Life Science in kind towards our development. We're almost at design freeze of the bandage itself. Our goal is very straightforward: to get to market. No clearance required for the bandage itself, so we hope to get to that soon. And then again, filing the breakthrough device. Revenue projections are based on sales of the bandages, starting 10,000, 50,000 to 100,000. We're currently trying to complete our raise with another $1 million. We've had incredible traction, small funding amounts, but good awards that help validate what we're doing. Again, talking potentially to Philips for Series A. We're already in talks for Series B with Hall Capital Holdings. Thank you very much. Reimbursement. You can ask me many questions about that.
All righty. Thanks for that excellent pitch. We'll turn the time over to the judges for some questions.
Could you share a little bit more about both the cost to create the device and then how the pricing might work?
Yes. So to develop the device, we are milestone based with IO Life Science for the development. So it will cost $600,000 plus some materials to get us to beta testing the software and the sensors. Now, again, we're not wanting to reinvent the wheel with sensors. Our secret sauce is really the algorithm and how we use the algorithm. We're still in the process of cost of goods, but our goal will be to have our device likely in the 125 to 150 range for the sensor, so that it's still lucrative reimbursement for remote patient monitoring, actually the remote therapeutic monitoring as well, because our software will include pain assessment. We do have a demo that was created by my son, a Georgia Tech student. So it was valuable enough to take into Philips to show them what their demo is missing. But yeah, that we're in development of that now.
This is really great. I can see how it can be, integrated into TPI workflow. My question is more around like data integration, and as you know well, like even getting vitals from EMS and getting that into the system can be challenging, and that to push forward patient care. And so I think you guys have like a screen, right? There's like a screen or something displaying the vitals alongside the bandage itself. I guess the question is, how do you get the data from that device into the system? Or maybe that's not super important. It's just more for key management.
Yeah, so it will be integrated. We're looking at different companies like InterSystems. We're looking at how AWS can provide some integration. Our goal will be to fully integrate from ePCR, the platform for ambulance, to go into the EHR. And to do that, we really want partnerships. We're talking to companies like Zoll. I chatted with Zoll Business Development at yesterday's meeting. And we're talking to a number of AED machine companies as well, for some data sharing and to help with the transmission of data as well. The goal is for it to go through just a series of brief screens, kind of akin to the one-liner pitch we heard before. You take a photo of the patient, but it's going to be dynamic. We're already drawing artificial intelligence out of the photo, looking at pupil dilation, bruised eyes, raccoon eyes, to look at level of risk, age, gender, looking at back-end risk profile, and then the sensors will via Bluetooth be analyzed against the platform where the EMT or ER nurse will enter nausea, vomiting, etc. It will spit out a summary. And all of that will flow through. Our goal is to integrate it into, Epic Athena.
I guess I have another question if no one else has one. Just going back to your reimbursement slide, that's hospital reimbursement, just to clarify, right? So EMS wouldn't be billing those codes. So I guess the question is like the incentive, maybe just from a financial perspective, like the incentive from an EMS agency to pick this up if they're not seeing the bills for it.
Yeah, so the incentive would be a time factor. So like the earlier discussion with EMS, if, right now in Florida, let's say, if you treat on the ground and don't transport them, they're not covered. And so you want to make, so the goal is if you can treat them faster and have more rapid turnaround, whether or not you're transported, you can make more runs. So by saving minutes on the ground by a faster bandage, minutes on the ground because you're not putting on a cuff, an oximeter, counting respirations, all of that, we're bundling it all so you can do more of the scoop and go. Eventually, we would like this, system, the sensors, to go into the hands of law enforcement as well, because they often show up first. And so it's a way to have a solution where, I see this as better than telemedicine in a sense, because you guys are tapped out time-wise. I mean, there are too few, physicians and nurses as it is, and now you're being demanded to sit in front of computer monitors to engage with other groups that you didn't have to necessarily before. So our goal is to take your clinical decision-making and the back-end algorithms so that we can put it into the hands of people earlier, so that first responders have better decision-making tools, nurses have better decision-making tools, and then the data flows to you and you see, okay, yes, there's somebody on the way, but I don't need to waste my time getting a verbal handover. I've got it right here, and I'm going to double check it anyhow. So it's a time saving for cost saving, and of course, patient life.
Have you received any concern or pushback among potential end users with regards to the ease of getting the bandage on? And I say this mainly because many patients who have head trauma are also there's a concern for there to be neck injury. And so can you talk to me about the ease of putting this on when neck injury is still an unknown?
Very good question. That's why we have an advisor who's an ER physician on our team. We've had lengthy discussions about whether the bandage would be placed before a collar goes on or after, and how the strap would go. The goal of this bandage, and on our website, you can see a little demo of how you don't need to manipulate the head as much. And so that's really, it can be torn into a flat configuration to place it under and on so that you're not holding the head up and wrapping. And we have videos from our simulation study at the Mayo Clinic where you can very well visualize the issue. You have somebody who was just in neurosurgery and their head's being manipulated to bandage them. So we have not had pushback. In fact, it's been the opposite.
You mentioned military as well. Is there also a potential consumer application, for example, sports teams or high school soccer teams, etc., having one of these as part of their kit?
Absolutely. So I just signed an NDA with this company in Somerset, New Jersey. They run this high-end lab that does a lot of movement sensing, ergonomics, cardio for high-end athletes. So we're in talks about commercial use, and I've also listed us on CVS Health for sales of the bandage, along with other ACE supplies. Eventually, I'd like it to go into every kit. I talked to Johnson & Johnson here locally. They've shown me what's in their kits and how we could use ours for training purposes.
Thank you.
All right. Well, thanks so much again to our presenter here and to our judges for excellent questions. Thanks so much for taking time. I, for one, did not expect that I would see a 4,000-year-old mummified patient with a wrapped head wound today during this presentation. I don't know if all of you were expecting that, but I thought that was a cool contrast to an otherwise very futuristic conference.
Yeah, that's my dad happens to be an archaeologist, so I had to put that in. Thank you so much. I appreciate it.
Yes, no problem. And thanks to all of our presenters who presented over the last hour and a half. Really an excellent group of companies that are doing some really innovative things in our healthcare system. As a reminder, so at 2:00 Pacific time, so in just a short 16 minutes here, we are going to have the closing ceremonies for the entire conference. That is going to be in a different digital room. So go back to your agenda and you will find that that is also where we are going to be announcing the winners of this pitch competition. So you don't have to sit on the edge of your seat for too long. That's just 15 minutes away. But we are going to close down this room for deliberations. Thanks everybody again who presented and everyone who's attended. Hope to see you in a few short minutes at that closing ceremony.
Thank you. Thank you.
Hey, great work. Thanks, everybody.
And judges will stay here for our deliberations. You'll see we'll